Konya. I'm Senior Innovation Strategist at ONC. I get to work on a lot of very interesting projects, and I can think of none that are more transformational, honestly, than the FHIR Scale Taskforce, which relates obviously to the Da Vinci Project. And today, hopefully, what you come away with is a greater understanding of both of those and how they relate to each other. We know there's been a lot of times where they've been confused with each other. So with that, I want to talk a little bit about what this panel is all about. If you take away nothing else, know that obviously there's a transformation towards value-based care that many people are working towards. And in that effort, we know that there are certain technical challenges and barriers, things that need to be done from a functional standpoint as well as an infrastructure standpoint. And today we've got two efforts, two collaborative FHIR-focused efforts that are working to create kind of that pathway for helping institutions like payers and providers and others ultimately achieve getting to value-based care through greater data sharing. So today on our panel, we're going to try to address a couple things here. One is, again, to make sure that you have a good understanding of what the Da Vinci Project is all about, what they're currently working on, their status. Also, we're going to talk about FAST, let you know kind of its genesis there, and more recently what it's been focused on in its progress as well. And then we're going to dive in a little bit deeper, ultimately explaining how the two relate to each other, taking a few of the actual use cases that Da Vinci's working on and running them through the FAST process. So you see a nice linkage on it. The goals, again, improve that industry awareness, to highlight the differences, and then ultimately understand how the functional industry use cases can inform the FAST infrastructural approaches to FHIR scalability challenges. So very fortunate to have 4 panelists with us that are involved in both of these efforts. They're going to be representing today. We've split them up 2 on each and said, let's try to focus on their side. But they are all involved in all these efforts and actually in many of the other collaborative efforts that are going on. So we're really lucky at the wealth of knowledge we have here. First, on my left here, we have Ms. Jocelyn Keegan. She's the Da Vinci Program Manager. She's also with Point of Care Partners and also is involved on the FAST project as a consultant. We've got Viet, the Da Vinci Technical Director with Stratemetrics. And the 2 of them are going to be covering bringing you up to speed on the Da Vinci Project. And then further, the 2 on the left on the end here, we have Patrick Murta, one of our chief architects for the FHIR Scale Taskforce of the FAST initiative. And he's also a Da Vinci operating member, solution architect fellow for Humana in his day job. And then Bob Dieterle, the FAST coordinating committee member, one of the founding members, and also serves as a lead on one of our, we just ran out of real estate to put everything here, but also a lead for one of our Tiger teams, the directory versioning and Scale Tiger team. He's a co-lead there. And then also serves as the Da Vinci PMO Senior Advisor with Enablecare. So with that, I'm going to turn it over and dive right into the meat of the program and hand it over to Jocelyn and Viet to take us through Da Vinci.
Thanks, Devin. I'm going to stay back here. I don't generally need to be amplified, so I think that we're going to give you guys Da Vinci what normally would probably be a 30-minute presentation in about 15 minutes, so we can get to the meat of the issue, which is really why is it that FAST is so critically important to make sure all of the hard work we're doing at Da Vinci can actually scale inside the industry. So I think that there's a couple, I guess, background sort of setting the stage pieces of information I want this audience to understand. You know, Da Vinci really, I think, was birthed out of the success of Argonaut and the ability for the industry to come together to develop a standard to be able to really make clinical data flow outside of the EHR. And so if you think about back in time, go back 2.5 years when we first started talking about Da Vinci as a concept, Chuck Jaffe, the CEO of HL7, Bob Dieterle from Enablecare, who's working closely with CMS, and Linnell James from Blue Cross Blue Shield Association, really sat down and tried to figure out, could we, as an industry, do for payer and provider collaboration what had happened with Argonaut, with providers and freeing up patient data. And we very quickly were able to identify thought leaders from EHRs, payers, provider organizations, the vendor community that really understood how critically important this was. And this is all against the backdrop of value-based care and the shift for moving from fee-for-service for how we pay folks to putting really payers and providers in risk-based contract models, that the need to share the critical information, the clinical information about these patients bidirectionally was going to become increasingly important. And I think that we thought at the end of the day, if we sort of got eight or 10 people to support us to start this project, that we'd be in good shape. And a number of things happened in the market that we don't have time to talk about today that made us much more popular, much more quickly than we thought. But I think the key, if you think about what we're doing with Da Vinci, it really is figuring out how to take the underpinnings that you get from a really, from FHIR as a technology standard, pair that with the subject matter expertise of the participants, hire the right people that sort of know FHIR well and bring in the SMEs that really understand the business domain and the problems incredibly well, and work on building common recipes or common implementation guides in order for that work to be done in a repeatable way and reused by people across the industry. And we very quickly got buy-in around the idea, and over about a 4-month period, we're able to get to the point where we launched the project. And if you think about it at its core, it was really the industry recognizing that if we didn't figure out how to do this in a standardized way, that we would just really cripple provider organizations and payer organizations by the data that needs to flow in order for these contracts to really work. And that what we're building at the very basic steps of what Da Vinci is standardized implementation guides coupled with reference implementations. So basically we write sample software to eat our own dog food and make sure that the IGs really work, bring those to connect-a-thons, and then we're supporting from a PMO perspective our members and the community to really figure out how to actually start to stand up and do early implementations and demonstration projects. So really pilot these standards so that we know that what we're bringing through the standards process will work. So because everybody always wants to see this, I refer to this as our NASCAR slide of membership. I would say from a membership perspective, and this is always available on the HL7 website for folks that aren't familiar with the project, and we keep it fairly up to date. There's a couple key points I would make here. I jokingly say that providers don't care as much about getting their logo up here. So we actually have many more providers that are listed here, but the vendors and payers seem to be more concerned about getting credit for the project. And that we've had amazing support from across the provider, EHR, payer, and vendor community in the 2 years that we've been around. And that what we've done over the last 1.5 years, 2 years, is actually start to also identify folks that are going to help us from a subject matter expertise area. So folks like HIMSS and NCQA are critical partners to us from our project perspective. And most recently, we've actually started to bring in membership for the folks that really are going to get us to scale in the industry, and we call those deployment members. So MyHIN has joined in the past year, and we've got Availity who's joined as of January of this year. And so that really is the idea of moving sort of from point to point to really that ability to bring in partners that are going to get us to multiple destinations through a single integration. And with that, I'm going to hand it over to Viet. He's going to talk a little bit about how we work and what the current use cases are.
Thank you, Jocelyn. So Da Vinci very much benefited from the early work led by HL7 and Dr. Jaffe around the partners in interoperability, recognizing the growth and adoption of FHIR many years ago, that we wanted to find the common use cases. So that group brought together providers, payers, pharma, other stakeholders, and what they discovered from these conversations was that there were many common use cases that came out of the discussions. And so when we first formed Da Vinci, we had about 9 use cases. And if you're familiar with HL7, the standards process in the past, an organization like CMS would come to HL7 and says, we need some standards for this domain, and then asked HL7 to find the community. We learned from Argonaut that there's a benefit to forming the community at the start of the process. And the community of the providers and payers and vendors define their own use cases and prioritize them, and through Da Vinci fund the work of developing the standard. So we started with 9, and the first year we completed 2 use cases, and then about a year ago at HIMSS 19 on the first day, we got our famous NPRM that we are anxiously or eagerly awaiting the final rule on. And thanks to Bob Dieterle, who really dug into it, identified some key requirements or proposed requirements for the health IT community. We created several more use cases. And so we look at this diagram to kind of how we organize our use cases. And from the top left, we have quality measures, and that's the framework of both defining quality measures and sharing them between payers, providers, and other quality stakeholders. At the bottom left, we have 3 use cases related to reducing burden for providers around the prior authorization process. We have a set of use cases to improve member access to data and exchanging data between payers and providers. We have process improvement use cases around identifying patients in risk-based contracts, and ultimately we're going to work on some improving missing documentation around chronic illnesses, and then additional use cases around sharing data and alerts and notifications for care. And so if you look at this, we have this year 12, I believe, use cases that are in mostly in ballot reconciliation or balloting right now, and then we have a couple more that are going into initial discovery and work, as Jocelyn described, around creating the implementation guides and the reference implementation. So pretty much all these use cases in blue are calls that you can participate in as part of the HL7 process. And so today, we want to highlight a couple of use cases around payer data exchange and getting information that payers have around the patient, the clinical data, getting it back to the clinician in order to provide the clinician with a more complete image of what's happening with the patient, because often any single provider doesn't know what other referrals may be done on a patient. And then a payer coverage decision exchange, which is maybe a little unfamiliar to folks, but we recognize that there's a challenge when a patient goes from one payer to a follow-up payer, and the need to have continuity of care as well as continuity of authorization. If a payer A authorized some services around a specific condition, chances are payer B will need to as well. And why can't we use the information that was already gathered as part of the first authorization and provide that continuity of care and try to decrease that burden on the patient to redo paperwork, as well as the provider to submit all this paperwork to reauthorize the care. So each of these use cases are really focused on that payer-provider exchange, but the reality is underpinning all these use cases are an infrastructure that we need that will be the focus of the FAST work. So here's our information. We are readily available through HL7's Confluent site, but we're happy to answer questions during this and afterwards. So, and that.
Thank you, Viet. So just wanted to say that the Da Vinci Project, I've just been blown away by the speed at which it's been working, honestly. When it came out of the gate early days, just getting the funding in place, and many of you were involved in helping get the organizations to cut the checks to help support the work. Seeing at how fast you got to balloting your first use cases and so on has been, I'm sure, no easy lift. And actually, if anybody, I get this question a lot from startups and others who say, payers don't, they're not serious about value-based care, or, they're not willing to share data, whatever, they're not, and providers are never going to share their data with them. I have to say, this is the example, these two efforts here, where I quickly say, aha, you're wrong. They have cut checks. They're not only just participating, they're funding, trying to standardize, APIs towards sharing data to automate things like prior authorization, et cetera. So it's nice for me to be able to come back and say all the payers and providers and others that are involved in Da Vinci are committed to this, and you can see that they're putting where their money where their mouth is. But that wasn't enough, right? And a lot of the same organizations that were involved with the Da Vinci Project, as it was getting launched, recognized and realized that this is great for developing these functional use cases, but there still is a whole nother set of issues around the scalability of these solutions. And ultimately, we need something else to address those infrastructure and technical barriers associated purely with scalability. How do you go from deploying something between one provider and one payer to deploying it between one payer and 30,000 providers in a short period of time? And so, although that was part of how FAST got launched early on, it was the payers and providers who came to ONC and said, we can't collaborate on some of these things because of antitrust laws, but we need a neutral party to help bring us together as a convener. Eventually, it quickly became real that we now needed to focus on not just payer-provider relationship, but FAST was really something that's going to support Da Vinci and also other efforts that are out there. And tomorrow morning, if you haven't seen it on the agenda, we have a whole nother session on FHIR collaborative efforts, where both of these efforts are going to go in a little bit deeper, and we have a few other collaborative efforts that we're going to talk about in that session. But with that, I'm going to turn it over to our FAST representatives on this panel. We're going to give us a little bit more history, exactly how FAST has got launched and ultimately evolved to where it is today.
All right, thank you, Stefan. And the presenting Da Vinci and FAST in the same session is actually quite brilliant, because understanding the Da Vinci use cases, and Viet did a great job of doing that, makes understanding FAST so much easier because they're very complementary to each other. And just as Jocelyn and Viet noted that Argonaut provides a basis for what we do from a Da Vinci perspective, Da Vinci provides or informs what we do from a FAST perspective. But before we jump into the cool technical stuff and the use cases, let me quickly recap what I think Stefan was talking about. In the sense that FAST, as an industry consortium, is ONC convened. We came together, which seems like an eternity ago, with only 2018, up in DC. Again, public-private, we've got payers, providers, EHR vendors, other vendors of software, others that I'm probably missing. So it's a varied group of folks that come together not to solve functional use cases, but to make sure functional use cases can run at scale. You know, what are the gaps? What are the barriers that would potentially limit Da Vinci, Karen, Argonaut, other industry consortiums from running at scale? That's what FAST is all about. Okay, so I've got some very, very simple graphics that I think will help illustrate this case, right? And I know the people around me are going to start cringing as I use this analogy because it's not popular, but it's pretty effective in the sense that functional use cases, such as those that Viet was referencing a second ago, are considered to be the cars, trucks, buses, even a little motorbike on this picture here. We have an ambulatory care center on the left. We've got a larger hospital on the right. They need to share information. Now, if you look at this model, the cars, trucks, and motorcycles actually do get from point A to point B and back. But it's not quite efficient because for every one of those functional use cases, they're laying their own roadwork, right? So messages can flow, but man, that is not going to scale. Compared to this model, in which, yeah, we've got the same vehicles, we've got cars, trucks, vans, and motor scooters, and they're all sharing a common infrastructure. So information is flowing from left to right and right to left, but not going in X's and spaghettis and stuff like that. They're actually sharing common infrastructure. And in the world of FAST, we consider the roadways to be analogs to implementation guides or whatever the case may be. So if you want a quick and easy way to differentiate and understand how Da Vinci and FAST complement each other, think about it as Da Vinci, cars, trucks, vans, motor scooters, FAST, roads, bridges, off-ramps, stoplights, street signs, whatever the case may be. That's a good way to keep it in line there. Okay, so when we started FAST a couple of years ago, quite honestly, we knew some of the barriers that we were going to face. So we looked at Da Vinci use cases, we looked at other things that were happening in the industry, Karen, Argonaut, others. We also looked at things that we knew were inherently inefficient in provider and payer workflows, right? I know that many of us in the room don't like to admit that, but there are some inefficiencies, especially as it relates to interoperability in healthcare. So some of the basic things that we knew we were going to have to address out of the gate are directory services. How do I discover when an endpoint looks like for a hospital or a payer or for the CDC or for an EHR or a population health company? In the previous world, we'd all have massive configuration files in which we would define every other endpoint. But when you're dealing on a national scale, that type of thing doesn't work very well. Also, identity. You know, in the old world, we could assert or say, hey, if you want to communicate with me, you've got to give me my ID. In the brave new world of interoperability, the ability or the mandate that you share or give me my ID back is not necessarily true. We all have to recognize that identity matching has to follow a different model. Security, of course, that's always very prominent in everything that we do. Testing, conformance, and certification, right? If we're dealing with a national model in which we're using FHIR to solve a lot of interoperability issues and make workflows much faster, quicker, better, we need to be able to trust each other's endpoints. And doing that requires a certain level of conformance, testing, and so forth. Also, the infamous versioning. I'm sure that everybody in the room knows that FHIR comes out with a new version at least once a year. And the fact that many of us are at different levels of FHIR, we need to be able to know, if I'm going to talk from point A to point B, what version of FHIR do they actually support? And also just scaling. Again, the meat of what we're doing from a FAST perspective is to make sure we can use the brave new world of FHIR to run at scale. You know, in today's world, no EHR system, no payer, no provider, no population health company is an island unto itself, right? We've all got to share information. All right, so with that being said, Stefan, I don't know if you want to say a few words.
You know, I think we can just dive right into, because I don't want to be too late on time, I want to have some time for some questions. Let Bob and you take it right through one of the examples, all right?
All right, let me use a current example that's very near and dear to our hearts, and that is the CMS NPRM that came out last March or February at the HIMSS that was mentioned already. We're expecting the final rule. If we assume that vast majority of what was in the NPRM will carry through, what we're doing is we're seeing a requirement that payers that participate in Medicare, Medicaid, QHP, CHIP all have to make their data available to their members, and at member direction have to allow that data to flow from plan to plan. The other part of the NPRM that is even more interesting is the ability to go and provide for continuity of care. So the ability to turn around and make sure that any current treatment, to the extent possible, is continued on into the next plan without either discontinuing it, if you're on step therapy, starting over again, or going back to a provider and asking for documentation, for example, for prior authorization that might have already been available at the prior payer. So there are really two Da Vinci use cases here, Viet's mentioned them, that are focused on it. One's called Payer Data Exchange, which provides the basic standards for exchange between the payer and a member's application for what's called USCDI, which is basically the core data set that ONC has promulgated, represented, for those of you who are comfortable with FHIR, as US core profiles. The other part of it is the ability to exchange that same data from payer to payer at member direction to allow for a member to go and continue their clinical record experience across payers. The other relevant implementation guide or use case is the payer coverage decision, which is the one to support current treatment portability across payers. Here we're talking about taking a current treatment like home oxygen therapy, providing the diagnoses that support it, any guidelines that support it, any prior authorizations that are currently in effect, and any past clinical history that would go and allow the new payer to go and take that data and say, yep, we need to continue that without disruption, okay? Those are the two use cases you're seeing here. So you see the member with the provider, you're seeing the provider interacting with the payer. The other aspect, by the way, to the payer data exchange is the ability to provide payer data to a provider to ensure that they understand the entire scope of treatments and interactions that the payer is aware of. So on each of these transactions, you'll see on number one, the ability to discover an endpoint. Patrick's talked about that as one of the important aspects that FAST is dealing with. Because if you look at the scope of what we're dealing with the CMS NPRM, there are 44 million Medicare members. There are 71 million Medicaid and CHIP members. There are roughly 200 payers that deliver coverage for the scope of what we're talking about between Medicare, Medicaid, and QHP. So we're talking about a substantial portion of the US healthcare environment. Probably 80% of all providers and maybe closer to 90% of all organizations that deliver care. So we have to find the endpoints, that's number one. We have to be able to authenticate you and authorize your access to data, that's number two, or security as Patrick was talking about. We have to deal with making sure we understand who the member is uniquely. Okay, that's matching patients, that's number three. And then ultimately what we have to do is we have to have a way to test this environment to make sure it works. We have 1,000 different EHR infrastructure products. We have a couple hundred payers, and we have to make sure that each of them agrees to and conforms to the same rules of the road, which is what we're really doing here with the testing and certification portion of the work that FAST is doing. So I think that covers this slide. Why don't I turn it back over to you, Patrick, to talk through some of the other material.
Thank you, Bob. And again, to kind of repeat the fact that we've got two Da Vinci use cases that we've been talking about for the last couple of minutes. And now we're going to talk about two fast infrastructure use cases to see how they complement each other. So Bob kind of set the stage in describing the Da Vinci use cases and also how fast complements that. And the slides that we're going to show here are just a little bit of a, an animated version of the same thing, right? And we're basically exchanging information when one member or patient goes from payer A to payer B, which under the proposed rules means that those payers have to share information so that we don't have members continuing to reset. If you go from payer A to payer B, it's kind of like resetting your phone. They have no clue what your authorizations are, your medications, whatever the case may be. So in this model, assume that scenario is continuing and that we have payer A on the left side, payer B on the right side, and we need to share information, right? So in this case, we're going to talk about the first challenge. So Da Vinci has created the use cases that define the payload of those transactions, right? We don't have time to go into them today. They're quite interesting, so I would encourage you to read those in your spare time this evening or tomorrow. But the challenge is Da Vinci as a functional use case provider doesn't get into the specifics of how you identify the endpoint of the other payer, right? That's beyond their purview. That's how fast and Da Vinci complement each other. So in this case, we've got the Da Vinci use case running. It needs to understand how to get to the endpoint for payer B, the old payer. So in this case, FAST has a solution in the directory infrastructure that it has defined or is in the process of creating a proposed solution. Payer A can discover how to talk to payer B without having that knowledge in advance, right? So it allows us to provide new endpoints, new services, new APIs dynamically and have a trusted mechanism for any other trusted entity in this ecosystem to be able to discover how to talk to the other side. All right, so the next challenge is, in this same scenario, again, payer A trying to get the old information from payer B so that the patient doesn't have to do a reset, is how do we agree on an identity, right? Because I can guarantee you, and working from a payer, I can say this with 100% confidence, that payer A and payer B don't share the same identifier, right? And the fact that we have to agree based upon certain criteria, it could be a FHIR match operation, could be collaborative identity matching. How do we agree that Viet is the same Viet on the left side as on the right side? Sorry, Viet. So that's quite a challenge.
He's looking right.
It was a generic
Did
name.
I sound right?
Stage right. You're good.
Stage right.
Okay, I'm gonna continue now. So in this case, based upon some of the work that FAST is doing with a task force that has a patient identity experts, is define the criteria for that operation. Again, they don't care what Da Vinci use case is operating. Could be this one, could be one of the other, any number of the other ones. The fact that they are only providing, or we are only providing, the identity matching approach is critical, right? FAST doesn't care about payload. FAST cares about making sure the infrastructure is there for those Da Vinci and other functional use cases to run at scale. All right, and in this case, we see a happy, smiling person in the lower left corner because the information has been received with the nexus of that beautiful Da Vinci use case and that beautiful, fast infrastructure. Everybody's happy, and information has been shared. I think we're just going to recycle through these. I do want to encourage folks. I know we're covering, as Jocelyn said, 3 hours of material in like 30 minutes. There is a link there, the FAST 101, in which we go, Paul and myself, go quite in depth on what FAST is all about, go through the additional feature sets, the core capabilities, the use cases behind it, and that type of thing. So again, if you're bored tonight, tomorrow, whatever, when you get back, from the ONC annual event, feel free to go through those. I'm just going to quickly walk through these. Our slides are just a little bit out. All right, so those are the contact information for Bob and myself. And Stefan, I think I'm going to kick it back over to you.
Great. Thank you very much for that. And again, I'm really excited to be part of this. One thing I do want to recognize, if somebody is currently involved in FAST, has contributed to the work and effort, I see we have our other chief architect, Paul, over here. If you could just raise your hand and kind of acknowledge this, because there really has been a large community that's been part of it. Not everyone can travel to DC. So I want to thank all the volunteers that have been part of giving countless hours towards working on this. All right, so at this point, is there any other thing that you'd like to say before we shift a couple questions here about what needs to happen and to ensure that there's better coordination in this complementary effort between the two?
So with my program hat on, I have a couple plugs I'd like to make while people come to the mic, if that's okay.
Yeah,
As Stefan mentioned, in addition to being the program manager for Da Vinci, my team actually supports the ONC FAST team to create the content and to take all the information that's coming out of the task forces to make sure, the Tiger teams, to make sure that it's human readable and digestible by laymen like myself. And there's actually a LinkedIn community for FAST. It's a technical learning community. It's a new concept ONC is creating to bring people in to give feedback on these documents. So if you look at the link that's in this presentation, or you go to LinkedIn, you can find the TLC, which I think is a good way to keep track of what's happening here. And then in addition, I doubled down on Stefan's commentary. Da Vinci works, and we're able to move as fast as we can because we get amazing in-kind contribution. All of us that are sitting up here work part-time on Da Vinci. It's not a full-time gig for anyone. And through the SME efforts, the subject matter experts and volunteers we get from the community, we're able to move as quickly as we are. And the model itself has been amazing. And my call to action for this group would be for folks that are on the fence or don't know how to get involved, definitely go to HL7 Confluence. We actually have a lot of content. We've worked really hard to make the project as self-service as possible, but you can pick up an implementation guide, look at our reference implementation, links to GitHub to download code, and join a call. Literally our mantra to folks is implement an IG, come to a connect-a-thon, or participate in one of the use cases. It's a really open environment. Everybody is excited to ramp new people up. So if you haven't been engaged, come in, the water's fine.
Yeah, another plug for engagement. We recognize that a lot of organizations are now recognizing the value and the importance of FHIR, and that it takes time to build that expertise. So we want to encourage you to pick up the IGs. Come to connect-a-thons. We had a really great one at the beginning of January, hosted by CMS. 300 people came together. It's a really great time for you to test out and learn about the implementations and learn from the community. Unlike the past where standards kind of come down from the mountain, FHIR is really a reciprocal relationship between the standards developers and the implementers who are proving out the standards as they're being developed. So we want more deep engagement by the implementer community. Thank you.
Great, thank you. Yeah, we're actually on the FAST side trying to be very inclusive and transparent, and the TLC is one example of that. We do post recording from webinars and things like that. Tomorrow, again, if you come to the session on the collaborative efforts, you'll learn more about the specific solutions that are being proposed and worked on, and you can actually view webinars on those. But Patrick, Bob, is there anything you want to highlight specifically for this audience today that they should be aware of, specific to the resources that we've put out?
No, good.
I would just echo the fact that there is really good material. Again, we condensed it quite a bit here, but I'll maybe even provide some additional context to some of the material. Is that if your organization is relatively new to FHIR or to interoperability the way that we're talking about it, you can catch up really, really, really quickly by using this material, right? So if it's foreign to you, I would encourage you from a sustainability perspective for your organization to take advantage of the work that's been done, because in a year or year and a half, you really, really want to be up to speed on this as far as implementations or whatever the case may be. So learn from our pain and come up to speed and join us on this journey.
And actually, that's a great point, because some of the materials in the FAST 101 are primers that you guys worked on putting together that are API 101, basically, that are FHIR 101. And so it's materials that this audience probably understands and gets and doesn't need, but as you go back to your organizations, you probably have leadership that says, I have no idea what FHIR is, what are you working on? It's a nice slide or two you can send to them and say, hey, this came out of an ONC FAST initiative, plus there's a couple of other materials. We want to make it easy for you to help educate internally at your organizations. Bob?
One of the things we want to encourage is, as you think of interoperability, as you think of how you're going to free up your data for exchange, look at the lessons of the people that have started, look at the lessons from CMS, look at the lessons from a lot of the EHR vendors. You have a fair amount of work to go and put in place something that'll take information that has typically been managed through portals, through batch processes, and get it into a position where you can access it in real time and make it available to the people that need it when they need it in their clinical workflow. That's something that is going to take you considerable amount of time within your organization to effect. So it's important to learn the technology, FHIR, learn the ways we can scale, the things that we're talking about here, but it's equally important to get your culture internally to look at how you free up that data and make it available in real time for the others that need it when they need it.
Great point. All right, so with that, we're going to open it up for some questions. There's a microphone in the center row here. If anybody has a question, please just get in a line, and we'll take them in order.
Is this the end of the day?
Yeah.
We've got the end of the day, Brad.
Here we go.
Thank you, Walter.
Our brave first man over the hill. Okay.
Thank you. Walter Swart with Kaiser Permanente and HL7 International. The Caring Alliance is developing a recommendation about a core health plan data set for consumers, a core consumer health plan database. Another acronym that's hard to really read, but how do you connect that work with the work that Bob that you just did?
Yeah, let me address that. The Caring Alliance has focused on creating a common payer data set for consumers as a way to go and do the equivalent of what CMS did with their Blue Button 2.0, basically to make claims data available through a FHIR API using what's called the explanation of benefits resource, okay? So it's really trying to go and use FHIR to do an EOB. We have used the same data model that they have done, where we're taking claims data and re-expressing it as clinical data. So in other words, putting it into this US CDI standard. So a claim would be an encounter, it would be a diagnosis or a condition, it might be a procedure, it might be an observation. For example, I've ordered a lab test. Okay, those are the things that we're using their data model to accomplish. The other things that go into it are things that are not part of that common model, which are the clinical data that's accumulated from standard clinical transactions, from CDAs, from other things where the payer has information that did not come from claims, but needs to be commingled with the claim information to give a full picture of what's happening clinically with the patient as far as the payer knows it. Okay?
And just a little bit more color, that's a really good question, because many of us were involved in the CPCDS, which I think you're referring to. Yeah, so the initially, I think for many of us, they were separate initiatives in that we had native EOBs, and then we were coercing the CPCDS data. But we have actually, I think from an organizational perspective and also from a FAST perspective, we have refactored some of the initial use cases to include the consumer mediation component. Again, FAST doesn't care about the content, but some of the use cases were refactored to make sure that consumer mediation, my dramatic prop, which I haven't used yet today, is able to serve up the type of data that you're referring to, right? So I think over time, those two initiatives, although they're kind of siblings at this point, will share, like as Bob was describing, a similar path.
Genevieve?
Genevieve Morse, Behavioral Health Strategies. So two questions, because there's no one behind me. So first, on the use cases that you guys are currently working on around the patient access and the payer data sharing, you mentioned authorization in earlier slides as part of the work that you're doing for Da Vinci and for FAST. How are you guys addressing making sure that a payer who says that they're the new payer for the patient actually is the new payer for the patient when they request the data? Like, what standards are you using to communicate that so that the payer who's responding has confidence that they're actually sharing the data in an appropriate way? My second question is around the identity matching. So I co-chair the FHIR Policy Work Group for Care Quality, and one of the discussions that we're having, particularly around patient access, is, you know, if you share the wrong data with the wrong patient, that is a HIPAA breach, regardless of it being one patient. And so we're trying to figure out how do we set appropriate patient matching standards and or levels so that folks are comfortable with those third-party apps accessing, not using the OAuth 2.0 standard, which negates that, right? But it doesn't really work long-term for what we want to do. So I'm curious as to whether you guys have started to address that, and if the answer is just OAuth 2.0, or if we are figuring out ways to address that issue that doesn't require me to reuse portal credentials.
So they're really, great question. They're really two different answers. Yes, we're using OAuth 2.0 where a patient's trying to access their data so they can sign on to their portal at their payer and authorize an application. I think the more important question was, how do we make sure that two payers are talking about the same patient? Right now, the expectation for version 1 of what we're going to do, I'll say it that way, is that we're going to do it from a deterministic point of view, not from a probabilistic point of view. So if you register with a new payer, you indicate the old payer's name, you will also have to provide your member ID for the old payer, and they will use those two pieces of information to go and say, I now have the new member, or that member, here is the information that they have provided me, and we're assuming that will be sufficient to locate that specific person's records with the old payer. Because we're doing it across covered entities, we have minimal risk if somebody were going to try to game that system, shall we say.
Are there any other questions?
While we wait for another question, I think that Genevieve, you did a great job of sort of walking into where I would say that we have what I affectionately refer to as robust discussions across the work groups, and to that point, I think that a lot of this is, you know, issues that are being grappled with way beyond the focus of what we're building for IGs for just Da Vinci, right? These are cross issues. Part of the reason these guys are focused on FAST, but that there are other entities in the market really grappling with how we're going to solve this universally across the project. And I always just want to make sure, because I tend to field a lot of these questions when we're onboarding new members or people are interested in picking up one of our IGs and using them. I just always want to be crystal clear when we're talking with folks is we're not solving sort of these age-old problems. What we're doing is we're forcing the implementers in the way that we're writing our IGs to be very thoughtful about how they're solving those problems in their initial implementations, while we look for projects like FAST to be able to propose solutions that can be widely adopted by the industry. And I think that that's really incredibly important, because I think often when new technologies emerge, that people assume that they're going to be these panaceas to fix everything. You know, we're still going to implement these new IGs just like any new, you know, effort that's happening in market, and there's going to be discourse and decisions about what happens with the first 5, with the first 50, that happen with the bespoke and custom integration work you do today. The goal is to remove the need for unique solutions so that we're focused on the big problems and solving the big problems and not spending time on table stakes. So I think that's an important takeaway, and that's why we really encourage you guys to pick up the work that we're doing and that the industry is putting forth, so that we can really exercise it and make sure that what ends up in your lap to implement is what you need.
Go ahead.
Hi, Linda Van Horn, iShare Medical. So my question, I hesitated to ask it because it's kind of a little bit, but you guys brought up this use case, so I have to go there. So in the land before time, I was the co-founder of the Pain Institute. We're anesthesia-based interventional pain group. We had 22 locations in 2 states, an ambulatory surgery center, and the Rehab Institute, which is physical therapy. And so we would get involved sometimes where a payer would be asking for medical records in the past, like give me the medical records on this patient for the last 2 years, when they had only been the payer on that for maybe 3 months. And legal counsel advised us that a payer does not have a HIPAA-compliant right to access medical records if they were not the payer of record on that data service. So it's a HIPAA question, and maybe beyond the group, but when I saw this in the proposed rule, I made the comment about that's not HIPAA compliant. A payer cannot have access to medical records when they were not the payer of record. So I was wondering if that's been now an exception that's been put in, or if anybody's addressing that or thought about it, or just throw it out to the universe as an open-ended question.
While Bob talks, I'm actually scanning the room to see if any of our CMS friends are in the room, but do you have a direct answer?
Yeah, I mean, there are 2 questions you raised. One is, how can you wind up having a new payer have access to old payer data? That is called by member authorization and direction, and they do have that right. So their right to that data and their right to move it to a new payer is all part of HIPAA. So it's member-directed exchange. The second one is there is a right under HIPAA for payers to coordinate care. So that is still HIPAA covered. Minimum necessary is still part of it. But if you take a look at the FAQs that were put out a few months ago from HIPAA, they indicated that a payer does have the right to get information from a prior payer to coordinate care delivery. So these are HIPAA-covered transactions, one on patient right of access and the other under coordination of care.
With the patient authorizing that access.
On the former, but not on the latter. The latter, they do not have to authorize.
Yeah, the patient authorizing makes sense, on the latter doesn't, but I'll
Yeah.
go look.
Yep.
Yeah.
So we actually pressed on CMS when this issue first came up in one of our numerous discussions, and our CMS contact actually worked with OCR, with the Office of Civil Rights, to run the issue down. And Viet and I were actually just on the phone with somebody from the privacy team within ONC to start to document that in a more formal way, so that there's clear-cut answers as to where we think it operates within. So I can give you my card when we're done, and I can follow up with information about what we're referring to there.
Are there any other questions? Final thoughts?
Yes, we want to put a plug in for those who came to the interoperability showcase last year and saw us do our demonstration of the various Da Vinci implementation guides made real. This year, we are putting it on steroids. And so we have 20 member participants and probably a similar number of their technology partners demonstrating any number of our implementation guides in real life. Some of the is demonstration as proof of concepts, but many actually are going into production this year, which is our big theme. And then we have, that's in our demonstration booth. And then we also have a theater booth right at the entrance of the interoperability showcase, where we will show a clinical scenario that expands on any one of these individual settings into a patient journey. And then we'll be talking about an end-to-end demonstration, as well as highlighting individual implementation guides and how our members are implementing them and making them real this year. So we invite you to join us.
And I would add on to that, I think from Patrick's earlier conversation about sort of, is this real? And Stefan's commentary around, maybe you understand this, but your leadership team doesn't. I think that the content that's created and available in Confluence is valuable, but I can tell you that I believe that part of the buy-in and the momentum that we continue to have as a project is really having those senior executives be able to see it in action for real at HIMSS. And so if you've got a leadership team that's going to HIMSS, definitely make sure that they spend time at our booth so that they can see both who's participating, the momentum behind it, and the real work that's being done.
Patrick, Bob, anything? Well, again, thank you all for choosing this session to be in. I hope you learned something today, clarified a few things. Thank you to our esteemed panelists. And thank you to all the volunteers of these efforts that aren't up on stage. So thank you very much.